the session with the MCQs. So let us start and keep on interacting. The first question: which is the best way to manage a patient with aspirin poisoning, which is acidic in nature? Now, suppose a patient has taken overdose of aspirin. How do you manage is the question. So answer: make urine alkaline by giving sodium bicarbonate, make urine acidic by giving ammonium chloride, treat with N-acetylcysteine, and do gastric lavage. So what is the best answer? Yes, Himalayan, Bhairav, DK. Can anybody answer this? Yes, the answer for this aspirin poisoning is make the urine alkaline by giving sodium bicarbonate. Correct, Bhairav. So what happens in acidic drug poisoning? If we make the urine alkaline, then the drug becomes ionized or water soluble and it is easy to excrete. So in acidic drug poisoning, if we don't get an antidote, then we alkalize the urine. One more example is we do it the same thing for barbiturate poisonings. What are barbiturates, sir? Barbiturates are this thing: phenobarbital, thiopentone, methoxytone. Now, by making urine acidic, we make urine acidic in basic drug poisoning. In basic drug poisoning, we make the urine acidic. For example, if a person has overdose of amphetamine, which is basic in nature, we make the urine acidic. I think 20-25 questions DK will do that. And N-acetylcysteine is an antidote for paracetamol. N-acetylcysteine is an antidote for paracetamol. And almost all the poison we do gastric lavage. So what is the message we get from this? What is the treatment for aspirin poisoning? We give sodium bicarbonate to make the urine alkaline. Okay, I hope you understood this. Now, why we took up this question? Because antidotes is a must know for FMGE exams. Any organophosphate and carbonate poisoning, the antidote is atropine sulfate. For atropine poisoning, the drug of choice is physostigmine. Don't confuse physostigmine with pyridostigmine. Why physostigmine, sir? Because it can cross blood-brain barrier. Beta blocker toxicity, the antidote is glucagon. Paracetamol, it is N-acetylcysteine. So keep revising with me. Digoxin, the antidote name is Digibind. It is also called as Digifab or Digoxin Immune Fab. You check any year of exam, these questions have come. Cyanide toxicity, it is hydroxycobalamin. Heparin, low molecular weight heparin, it is called protamine sulfate. Warfarin, it is vitamin K. Dabigatran, it is idarucizumab. I told you, अगर दारू मिलता है तो दबा दबा के पीना है, दारू दाबी. तो dabigatran, the antidote is idarucizumab. Rivaroxaban, it is 10A inhibitor. For that, andexanet alpha. And then benzodiazepine, Z-drug and beta-carbolin, the antidote name is flumazenil. Now don't get confused flumazenil with fomepizole. Fomepizole is for alcohol, that is ethylene glycol and methanol. For valproate-induced hyperammonemia, it is carnitine. Neuroleptic malignant syndrome, the drug of choice is dantrolene sodium. Opioids, it is naloxone. And if I give sulfonylurea and there is hypoglycemia, the antidote will be octreotide. Suppose we give a drug and there is dystonia, sudden neck turn to one side, then we use central anticholinergics like benzexol or promethazine. Methotrexate toxicity, we give leucovorin, also called as folinic acid or citrovorum factor. Calcium channel blocker toxicity, we use calcium gluconate. Methemoglobinemia, we use methylene blue. If I give isoniazid as a TB drug and there was seizure, we use an antidote called pyridoxine. Suppose there is fibrinolytic overdose, we use the antifibrinolytic. They are called epsilon amino caproic acid, tranexamic acid. Magnesium sulfate toxicity, we give calcium gluconate. TC overdose, we give sodium bicarbonate. Lignocaine overdose, we give 20% intralipid. This was tested. Acute iron poisoning, we give deferoxamine. Chronic iron poisoning, we give oral deferricerox or deferiprone. Now, you have to revise with me. Recently, the acute iron poisoning was asked, chronic is asked, lignocaine overdose is asked, TCA poisoning is asked. So this chart never miss. Most expected. You can check in the next exams. One antidote will be 100% asked. So I'll be sharing this after this session. So go through this. You can take this page, stick into your room and study this thoroughly. So let me ask you in the session only. And it's a quicker revision for us. Can you tell me the antidote for tricyclic antidepressant overdose? So please put your answer in comment section. What is the antidote for TCA overdose? Come on. Then tell me what is the antidote for opioid overdose? Yes, come on. Yes, you should be interacting. The session should be interactive. You should be telling me the answers. Yes, come on. For tricyclic antidepressant overdose, the antidote name is sodium bicarbonate. Correct? Very good, Gunvanti Srinivasan. For opioid, the antidote name is naloxone. Very good, naloxone. Yes. So this is why we chose this question. How to manage drug poisoning and what are their antidote. Now let us move to the second MCQ. Which of the following antimicrobials should not be given to a chronic asthmatic managed on theophylline therapy? The question is like this. And what are the options? Erythromycin, cefotaxime, cotrimoxazole, amoxicillin. So what we are testing here is drug interaction. So patient is taking theophylline. And which antibiotic if I give, there is a problem. The answer is A, erythromycin. Why erythromycin, sir? Suppose I give erythromycin. Erythromycin is enzyme inhibitor. Now what happens if I use this with theophylline? Theophylline will not get metabolized. Theophylline levels goes up. And theophylline will lead to toxicity like arrhythmia and seizures. So this is an interaction. The answer will be erythromycin. Yes, Bhairav, you're right. So what should I learn from this MCQ? I should learn what are enzyme inhibitors and what are enzyme inducers. The mnemonic I have told you repeatedly, vitamin K cannot cause enzyme inhibition properly. V for valproate, an anti-epileptic drug. K for ketoconazole, cannot is cimetidine, cause ciprofloxacin. E, erythromycin. I, isoniazid, properly is protease inhibitors. I hope you are clear with this. Coming to the inducer, GPRS cell phone. G for griseofulvin, P for phenytoin, R for rifampicin, S for smoking, C for carbamazepine and phenobarbital. If you see here, most of the drugs are for epilepsy. Phenytoin is for epilepsy, carbamazepine is for epilepsy, phenobarbital. Most of the anti-epileptics are inducers, except one anti-epileptic, that is valproate. Now tell me what happens if a lady is taking OCP and for her if we give rifampicin, what can happen? And let me remind you, rifampicin is an enzyme inducer. So what will happen? What is the interaction going to happen? The OCPs are going to be metabolized faster, so that will lead to contraceptive failure. This is tested repeatedly. Contraceptive failure can happen. So let us revise the mnemonic again. Vitamin K cannot cause enzyme inhibition properly is for enzyme inhibitors. GPRS cell phone is for enzyme inducers. Correct? Yes. So you have to revise with me. Moving on to the third question. 32-year-old patient had anaphylactic shock and he was given injection adrenaline 1 in 1000 by IM route. The actions of histamine are antagonized by adrenaline. This type of antagonism is called. Yes, most of you know it. Now we know that the drug of choice for anaphylactic shock is adrenaline. The drug of choice is adrenaline. Okay? Now why do we give adrenaline? Because the culprit which causes anaphylaxis is histamine. All the actions of histamine can be antagonized by adrenaline. But histamine acts on its own receptor H1. This one acts on alpha and beta. So the receptors which they act are different, actions which they produce are opposite. Then we call them as, yes, you are right, physiological antagonist. So when to call physiological antagonist? If they are action on different receptor and the action produced is opposite, then we call it as physiological. What is chemical antagonism? Chemical antagonism means the action will be having, the antagonism will be having chemical reaction. For example, HCl. How do I antagonize HCl? By giving antacids. For example, chelating agents. For example, heparin protamine sulfate. What is competitive antagonism? Suppose this is a receptor. If both agonist and antagonist, both of them try to bind to the same site, it is competitive. Suppose this is a receptor, the antagonist bind at other side, agonist bind at separate side, then it is called non-competitive antagonism. I think most of you know it. So they are asking what is the drug of choice for anaphylactic shock, adrenaline, we know that, but what they asked in the FMGE is what is the antagonism between histamine and adrenaline called? Physiological antagonism. What should I learn from this MCQ? What are the use of adrenaline? Adrenaline can be used in 1 in 1000 dilution. What route I can give? IM, subcutaneous and nebulization. Mainly where we use it, anaphylactic shock. Remember that. 1 in 10,000 I give it by IV, IO or endotracheal. Mainly it is used in cardiac arrest and anaphylactic shock. 1 in 50,000 to 2 lakh it is used with local anesthetics. So this much point you should be knowing. So this is adrenaline. Now I will ask you some questions here. What do you mean by vasomotor reversal of Dale? So this is again tested again and again in FMG exams. What do you mean by that? The meaning is when we are doing experiment on dog BP, first we give alpha blocker. After that we give high dose adrenaline. We give high dose adrenaline. Then what happens to the dog BP? You have to answer me. Whether it falls or rises. Come on. I know there is a lag, but you can answer this. Come on. So there will be fall in BP. This fall in BP is what we mean by vasomotor reversal of Dale. And this is tested frequently. Now, whenever I teach you adrenaline, yes, Chandani Pandey, you are right. Srinivasan, you are right. Now, one more favorite drug for FMG exam is noradrenaline, also called as norepinephrine. Frequently, they keep on asking this. This one acts on alpha 1, beta 1, but it has no beta 2 action. So because of this, it increases diastolic BP, systolic BP, and it increases mean arterial pressure. So when we give noradrenaline infusion, it increases all the BPs. Now tell me, after infusion, will it increase the heart rate or decrease the heart rate? Tell me. So you have to tell me, if I give IV infusion of noradrenaline, after some time, will the BP, will the heart rate go up or go down? Please answer me. Very, very important, this one. Now, noradrenaline is a drug of choice for any shock with hypotension. So it's a drug of choice for any shock with hypotension. But it won't work in one shock, which is the shock noradrenaline will not work. It will not work in anaphylactic shock. Why, sir? It has no beta 2 action. That's why. So nobody answered this. Come on. Now when we give IV infusion of noradrenaline, since all there is this thing, BP has raised, there is activation of baroreceptor. So when this baroreceptor gets activated, this will be this will be detected by the brain, and that will activate parasympathetic system, releases acetylcholine, which acts on M2 in the heart, and you see decrease in heart rate. That is called reflex bradycardia. So this is, yes, very good, Sai Gunvantri, very good. So remember this, noradrenaline never decreases BP, but when you give infusion, there is reflex bradycardia. And why this happens, that is also been tested in FMGE exam. Correct, sir. So it's a drug of choice for any shock with hypotension, but it's not going to work in anaphylactic shock. So we understood adrenaline, noradrenaline, very, very important, two drugs. Next, move on to the next question. Mr. Swami, aged 48 years, comes to the OPD with complaints of drooping of eyelids, difficulty while chewing food, weakness of upper and lower limbs, which fluctuates in intensity over time. The physician wanted to confirm myasthenia gravis. So patient had ptosis, muscle weakness, which was increasing as the day was progressing. How do I diagnose myasthenia gravis? In simple words, what drug is used to test or diagnose myasthenia gravis? Come on. Come on. Everybody knows the answer. You have to attempt here. Yes, very good. The drug that is used is edrophonium. So edrophonium is a drug which is used to diagnose myasthenia gravis. It is also called as tensilon test, and most of you have answered. Sometimes if edrophonium is not available, then we can also use neostigmine to diagnose myasthenia gravis. So this is point most of you don't know. If edrophonium is not available, we can use neostigmine for diagnosing myasthenia gravis. So there are certain points I want to tell you here. Okay, let me tell you. So first point is, what are the uses of neostigmine bar pyridostigmine? This is frequently tested drugs. Neostigmine, pyridostigmine, these two drugs are used to manage cobra bite. Why in cobra bite? To improve muscle weakness. Second, they are used in myasthenia gravis. Third, they are used to reverse. Non-depolarizing skeletal muscle relaxant. Sir, tell me some examples, sir. D-tuberculin, or the drug ending with curium, or the drug ending with curonium. Suppose we use them as muscle relaxant, I want to reverse it, then I can either use neostigmine or pyridostigmine. Now, if you know this, tell me what is the drug Sugammadex used for? Sugammadex is used for what? Yes, Chandini Pandey, you're right. Absolutely correct. What is Sugammadex? Come on. You all know it. Sugammadex is also used to reverse two muscle relaxant. Remember rho and V. Rho means rhocuronium. V means vicuronium. Yes, very good, Gunavartini, sorry. So Sugammadex, this is tested. Neostigmine, pyridostigmine is tested. So very, very important. Then coming to drugs used in Alzheimer's disease, Alzheimer's. Now what neurotransmitter is decreased in Alzheimer's disease is acetylcholine. The drug we use is mnemonic is guard the memory. What is GA for galantamine? R for rivastigmine, D for donepezil, M for memantine. Okay. Yes, very good. Sugammadex and neostigmine, if I compare, Sugammadex is faster acting compared to neostigmine. So rapid reversal, very good, Lakshman and Sai, very good. Suppose in the option you have both to reverse rhocuronium, if you have both neostigmine and Sugammadex, check. Sugammadex is the best answer. So Alzheimer's disease, I was telling you, galantamine, rivastigmine, donepezil, and memantine. Earlier there was a drug called tacrin. Tacrin is not used nowadays due to hepatotoxicity. Yes. So this is about this MCQ. Let us move to the next one. A 22-year-old pregnant lady. See, one thing I want you all to observe when you solve this exam questions. When they give lady, check whether they are given pregnant woman or not. She has vomiting and nausea more in the morning hours. Which of the following drug is preferred? So usually a lady vomiting, nausea in morning, it is usually diagnosis of morning sickness, particularly in first trimester. So what is the drug of choice for morning sickness? Yes, most of you are right. It is doxylamine plus pyridoxine. Yes, Irfan, I'll write. Okay. It is doxylamine with pyridoxine. So what should I learn from this MCQ? What is the drug of choice for morning sickness? They will ask you. It is doxylamine plus B6. Then what is the drug of choice for acute mountain sickness? Acute mountain sickness is also called as high altitude sickness. High altitude sickness, the drug of choice is acetazolamide. Very good. Yes, doxynate, doxylamine, both are same, Lakshman. Now, can you tell me, it is a carbonic anhydrase inhibitor. Tell me which part of nephron acetazolamide works. Come on. Acetazolamide is a carbonic anhydrase inhibitor, correct. It is given for prophylaxis and treatment of high altitude sickness. Which part of the nephron it works? So number 1 we answered, number 2 we answered, number 3 motion sickness, the drug of choice is either we give hyoscine, if not there then promethazine. Yes, the treatment is descent, Lakshman. Obviously the treatment is descent, but the question if they ask you what is the drug of choice, then acetazolamide. So the site of action of this acetazolamide, as most of you are told, it is proximal convoluted tubule. So please read the questions carefully. Morning sickness is in pregnant women. Mountain sickness is seen when you go to high altitude like Leh, Ladakh, Himalaya, like that. If you go to Chota Mota mountain, that will not happen. Suppose you travel and you get vomiting, that is called motion sickness. These are all different things. Don't confuse them. Correct? Yes, sir. Then coming to the next question. A patient came with pain in first metatarsophalangeal joint. Whenever they give first metatarsophalangeal joint, I will go with the diagnosis of gout in my mind first. And next, the patient has high uric acid level. He was diagnosed with acute gouty arthritis. Which of the following is not used in the treatment of acute gout? So I am giving you the time to answer this. Please answer. Lakshman, if you are going for long trip like sea sickness, then we apply patch. So what is not used for acute gout? Remember, indomethacin is an NSAID. It is the drug of choice for acute gout. So we use the drug in acute gout. Prednisolone is also used in acute gout. Colchicine is also used. What is not used is pegloticase. So pegloticase is not for acute gout, it is for chronic gout. So the answer is B. So what should I learn from this? Drugs used in gout. Very, very important topic. Tested frequently in your FMGE exams. Gout, small topic. What are drugs used for acute gout? Acute gout, the drug of choice are NSAIDs. They are the drug of choice. Then we can use colchicine. Colchicine inhibit microtubule and also it inhibits neutrophil chemotaxis. And then we give steroids. So 3 drugs are given in acute gout. Tell me which NSAID is contraindicated in acute gout. Tell me that. Let me take one more page and tell you drugs used in chronic gout. So we use a xanthine oxidase inhibitor. XO means xanthine oxidase inhibitor. The name is, I told you in the class, it is allopurinol. Allopurinol. It is a drug of choice for chronic gout. Yes, you are right. The NSAID which is not given in acute gout is aspirin, because aspirin itself increases uric acid and worsen the gout. Chronic gout, the drug of choice is allopurinol. If that is not there, we can use febuxostat. Then we have uricosuric drugs. Mainly remember the name probenecid. Then lesinurad. And then we have enzyme. The enzyme name is pegloticase. So these are the drugs for chronic gout, and the drug of choice is allopurinol. Now, where is raspberry case used? Very good. Somebody came up with this raspberry case. Raspberry case is not approved for gout. Same mechanism, but it is used for tumor lysis syndrome. What is TLS? Tumor lysis syndrome, where there is increase in uric acid. So there we use raspberry case, but pegloticase is used for chronic gout. And what are they? They are the one which will convert uric acid into allantoin. They will convert uric acid into allantoin and decrease the levels. Yes, very good. So please understand, gout is a small topic, but every year question keeps on coming from this. Let us move to the next question. Which of the following diuretic acts by inhibiting sodium potassium 2 chloride sympod? Try to answer this. The answer for this question is furosemide, loop diuretic. The major site of action of loop diuretic is thick ascending loop of Henle. Chlorthalidone is thiazide. Their major site of action is early part of DCT, and they inhibit sodium chloride sympod. Astazolamide, I just discussed. PCT inhibits carbonic anhydrase. Spironolactone, collecting duct. It is aldosterone receptor antagonist. If you know all these things, tell me what is the mechanism of amyloride. Expecting your answers. Then we have mannitol. Mannitol is osmotic diuretic. Yes, anybody? What is the mechanism of amyloride? It is ENaC inhibitor. ENaC stands for epithelial sodium channel. Particularly, it blocks that in collecting duct. Yes, Chandini Pandey, you are right. So what did we understand from this MCQ? We understood diuretic and their site and mechanism of action. Then coming to the diuretic of choice for various edema. This is tested. Cerebral edema and acute congestive glaucoma, the diuretic of choice is mannitol. Nephrotic syndrome, pulmonary edema, furosemide. Cirrhotic edema, it is spironolactone. Very good, Dr. Strange. Liddle syndrome also we use amyloride. Amyloride is also drug of choice for lithium-induced diabetes insipidus. Now, suppose a person has hypertension and repeated calcium renal stones. Tell me which diuretic will you prefer? The last one is for you people to answer. Patient has hypertension and repeatedly is getting stones, calcium stones. Then which one will you prescribe? Come on. And that is a NEET PG INICT level question. It can come here also. Yes, very good. Thiazides. Why thiazide? Because thiazides retain calcium and prevent the calcium stones. So this is what you have to keep in your mind when you revise diuretics. Next question, 44-year-old male patient has history of chronic gout. His BP is now 156/90. So please remember, patient is having hypertension plus gout. And the physician decided to start him on ARB. So he want to give ARB, which is a sartan, for managing hypertension. Which one of these is best to this patient? So try to answer it. So if you are telling losartan, then you are absolutely correct. Losartan start with low. That means it lowers two things: thromboxane A2. It lowers uric acid. Now, can you tell me among these four options, which sartan is the longest acting sartan? Tell me. Now, there is something called R9. R9 means ARB with neprilysin inhibitor. The combination is called valsartan plus sacubitril. Yes, which is the longest acting sartan? Yes, it is telmisartan. Usually in pharma, the drugs starting with T are usually long acting. Telmisartan. Then we have tadalafil. But one exception you should all remember. Yes, Gunavand has told that propicamide. Propicamide is the shortest acting passive mydriatic. The longest acting passive mydriatic is atropine. So that one you remember. If you don't know anything in the exam and if they keep on asking which is the longest, check for T. Yes. Now, what should I understand? Adverse effect of AC inhibitor. AC inhibitor, they can cause dry cough. So if they develop dry cough, change the patient to ARB. Second problem they can cause is angioedema. They can ask you the image-based question. There can be swelling of the lips, tongue, glottis, everything. And now you know that these two are due to increase in bradykinin level, and it can increase potassium. The question is, can we give it in pregnant women? You have to answer yes or no. So it increases potassium. Pregnant, tell me. It decreases blood pressure. Pregnant woman, it is absolutely contraindicated because it is teratogenic. It can lead to renal agenesis. Suppose a pregnant lady comes to your clinic and she tells she is hypertensive, don't give AC inhibitor or ARBs. No, very good. So that is about AC inhibitor. 58-year-old male patient was started on Digoxin for chronic CHF as he started having dyspnea and weight gain. What is the mechanism of action of Digoxin in this condition? So Digoxin is a cardiac glycoside, we all know. It is used in chronic CHF because it is the one which increases force of contraction in the heart. How? What is the mechanism? It inhibits sodium potassium ATPase pump. That is the mechanism. Digoxin is also used in atrial fibrillation. Why it is used in atrial fibrillation? Because it causes AV blockade. What should I know about Digoxin? I know mechanism. Then what else I should know, sir? See here. Digoxin, what they ask you is, what is the drug of choice for Digoxin-induced VT? This one is for you guys. Answer me. For SVT, we use beta blockers. The antidote, just now I told you, digibind or digifab. Can I do dialysis if there is digoxin poisoning? No, because it has high volume of distribution. Most common adverse effect of digoxin is your favorite, nausea, vomiting, diarrhea. And very rarely it causes gynecomastia and xanthopsia called yellow vision. Yes, you are right. The answer for this question is lignocaine. Lignocaine is also called as lidocaine. All are same only. Lignocaine, lidocaine, they are same drugs having two different names. Correct? Yes. Next question. A patient, 52-year-old patient has history of angina and heart rate of 94 beats per minute. So angina है, heart rate थोड़ा बड़ा है 94. Also has tension personality. BP is also high. So hypertension. The preferred drug in treatment of hypertension in this patient: thiazide, metoprolol, amlodipine, telmisartan. Yes. Come on, guess. The answer is beta blocker. Why, sir? Because beta blockers can treat angina. They can decrease the heart rate. They can treat the tension personality, that is performance anxiety. It can also treat hypertension. So metoprolol is the answer. I don't know why you people are choosing CCB. Why you are choosing CCB? CCBs will not take care of the tense personality or the increase in heart rate much. So that is why it is beta blocker. It's a old question. Even though it is cardioselective, doc strange. What do you mean by cardioselective? If there are beta 1 and beta 2, cardioselective blocks beta 1 more than beta 2. That is the meaning. It also blocks beta 2, but more of beta 1. That is the meaning of cardioselective. So I will go for metoprolol. Because of these comorbid conditions, I have to go for beta blocker. And this is not the question framed by me. It is already been tested in your FMGE exam. So what should I know here? What are the first line drugs for hypertension? They are ACT. What is ACT for? AC inhibitor or ARBs. C for CCB. T for thiazides. Correct? So any patient coming to the hospital, we give any of these three. Suppose patient, after giving these three drugs, still resistant to hypertension, we give spironolactone. Now I just asked you this question: hypertension with gout, I can give losartan. Now tell me, hypertension with gout, which diuretic you should avoid? Tell me this. Suppose a patient has hypertension and gout also, which diuretic I should avoid? Hypertension with BPH, prazosin. Hypertension with diabetes, CKD, proteinuria, either AC inhibitor or ARBs can be used. Yes. Now tell me, for this is first point, second point, third point, fourth point, fifth point. Yes, very good, Irfan, Lancelot. It is thiazides. We should avoid thiazide because thiazides themselves increase uric acid. So avoid, and that was your FMG question recently asked. Very good. Okay, sir. A 32-year-old pregnant lady, again when they give lady check, yes, she is pregnant. BP 152/96, which is the first choice antihypertensive drug in pregnancy? I think it's a simple question. The drug of choice for this lady is labetalol is the drug of choice. All others are also used, they are safe, but the drug of choice is labetalol. Yes. Now tell me, suppose the pregnant lady, I will give you three scenarios. She has hypertension also, asthma also. Will you give nifedipine or will you give labetalol? Choose any of these two. Sir, I will choose nifedipine, sir. Why? Labetalol is non-cardioselective, which can cause bronchoconstriction and worsen asthma. So I will choose nifedipine in this case. Which antibiotics are safe in pregnant women? PCM. Penicillin is safe. Cephalosporins are safe. Macrolides like azithromycin, erythromycin are safe. Yes, very good. Lancelot, Gunavartini, very good. Which antibiotics are absolutely not given in pregnant women? Teratogenic. Fluoroquinolones, you know, they end with fluoxetine. Why, sir? They cause cartilage damage. AGs means amylglucoside like streptomycin, gentamicin. Let me give an example, amikacin like that. Why we don't give, sir? They can cause ototoxicity in the fetus. T for tetracycline. Why not tetracycline in pregnant women? They can cause teeth and bone damage. Now another antibiotic I'll tell you is sulfonamide. Now sulfonamides, we don't give it in newborn. Why, anybody? We don't give in newborn, or we don't give it in last trimester of pregnancy. Why? Anybody can answer this? We'll be waiting for your answers. Because sulfonamides can cause bilirubin displacement. Bilirubin displacement. So what will happen if you displace bilirubin? The levels of bilirubin goes up, they cross blood-brain barrier, and baby may develop kernicterus. It's not teratogenic, but it can cause jaundice or kernicterus. I think most of you didn't answer this, so just look into these things. Again, pregnant women. Why you are asking so many pregnant women questions? Because that is how the questions are getting framed recently. Pregnant woman was on drug during pregnancy. The baby born had features: cleft lip, short fingers. The drug causing the following teratogenic feature is, any guesses? Not thalidomide, because it causes small upper and lower limb, that is called phocomelia or C limb deformity. Carbimazole will also cause problem like cutis aplasia, that is scalp defect and hypothyroidism. Warfarin will also be teratogenic, but it will mainly cause the depression of nose and skeletal abnormalities. So it is phenytoin. Phenytoin will cause cleft lip, palate, small digits, cardiovascular defects. Then it is obviously phenytoin. Phenytoin. How to identify warfarin, I will tell you. If they give warfarin, they will give you depressed nose. The nose feature will be depressed and there is skeletal abnormality. Then obviously you have to go for warfarin. So here it is phenytoin. So what are the teratogenic drugs you need to understand? Thalidomide. Misoprostol can cause Mobius syndrome. Warfarin, I told you, depressed nose. Remember that. Lithium, mainly remember cardiac abnormality, that is Epstein's anomaly. Isotretinoin can also cause cleft lip, cleft palate, heart and CNS defect, but it is not in the option, so I couldn't choose it. Phenytoin, we told you. Carbamazepine also cleft lip and palate. Neural tube defect, mainly remember valproate. Neural tube defect, mainly remember valproate. Suppose they give mental retardation, growth retardation, go for alcohol. And vaginal carcinoma, particularly in a female offspring, go for diethyl stilbestrol. I think Pallavi Gula, I have told you, isotretinoin will also cause the same problem, but it's not there in the option, so I cannot choose it. You can see isotretinoin causing cleft lip, palate, heart and CNS defects. I hope you are clear with this. So these are the major teratogenic drugs, and I told you how to identify. Let me repeat. Phocomelia means thalidomide, Mobius syndrome, misoprostol, then depressed nose, skeletal problem, warfarin, then neural tube defect, valproate. If there is mental and growth retardation, alcohol, right? So remember mainly this. Epstein's anomaly means lithium. Okay, So before I proceed, tell me whether the session is useful for you. Are you able to revise the things? How is the session? Please put your comment and then we'll proceed. Whether the speed is fine, please tell me. Okay, let me move on. A patient was recently started on haloperidol. This is again tested. Haloperidol is a D2 blocker, meaning it's a typical antipsychotic. It's a typical antipsychotic. Few weeks later, the patient developed tremors, rigidity and bradykinesia and excessive salivation. First line of management for this patient is, now whenever we give typical antipsychotic, there is a chance of extrapyramidal symptoms, EPS. The first one that happens is acute dystonia. The neck will turn suddenly to one side, or there may be uprolling of eyeballs. First one. Suppose we give the same drug to elderly, they may develop Parkinson-like symptom. So that is what the question is testing. So for these two conditions, the drug what we use is option B, benzhexol. Benzhexol is the treatment what we give. If benzhexol is not there, we can give promethazine. Sir, what is the other name for benzhexol? Benzhexol is also called as trihexyphenidyl. Now, guys, can you tell me an antiemetic which can cause dystonia, and there also we use the same drug. Tell me the antiemetic name. Please tell me. Selagelin is a MAO-B inhibitor that is used to manage Parkinson disease. Pramipexole, ropinirole, rotigotine, they are D2 agonist, but they are not ergots, they are non-ergot. Amantadine is also used to treat Parkinson disease. Particularly, it is used to manage a problem called dyskinesia in Parkinson disease. Yes, very good. So, metoclopramide is an antiemetic. When we give it to the patient, he may develop dystonia, and that is treated with benzhexol or promethazine. Very good. The treatment is benzhexol. Now, what should I understand? What are the other extrapyramidal symptoms? The other extrapyramidal symptoms what we see is patient may develop akathisia. How do you manage akathisia? The drug what we use is propranolol. If that is not available, then we give benztropine. That is also not available, then we give benzodiazepines, BZD. Yes, very good, Pallavi, you are right. The adverse effect of amantadine is ankle edema and livedo reticularis. Second problem, they may develop tardive dyskinesia. For tardive dyskinesia, we use VMAT2 inhibitors and they end with benazine. They are benazines. They are valbenazine, tetrabenazine, whatever. Now, you should answer me, what is the drug of choice for Neuroleptic malignant syndrome? NMS stands for Neuroleptic malignant syndrome. Yes, come on, you know the answer. What's the drug of choice? The drug of choice is dantrolene sodium. I think most of you will answer it. And it blocks a receptor called ryanodine receptor 1. And the culprit for neuroleptic malignant syndrome is calcium. Dantrolene is also drug of choice for another problem when we give anesthetic, and that is called malignant hyperthermia. So for malignant hyperthermia also the drug of choice is dantrolene sodium. What is malignant hyperthermia? If we give halothane or succinylcholine, the body temperature may go up. That time also we give dantrolene. Remember, extrapyramidal symptoms are frequently tested in your exam. So that's why we made a separate table. Yes, so answer for this question is B, benzhexol. Okay, sir. Morphine is used in following condition except morphine, yes. Can you use it in MI? Very good, yes. Biliary colic, no. Cancer pain, yes. Post-operative pain, yes. So morphine is not given in biliary colic. Reason is simple. It can cause spasm of sphincter of Oda and worsen biliary colic. So what are the contraindications of morphine? Contraindication. Number 1, biliary colic. Number 2, head injury patients we don't give. Head injury we don't give. Number 3, we don't give it in bronchial asthma patients because it will worsen the asthma by releasing histamine. Now you should answer me, can we use pethidine in biliary colic? Tell me yes or no, that's it, enough. Can we use pethidine in biliary colic? Please answer me yes or no. Now coming to some of the questions, opioid which has dual action, opioid and non-opioid action, the name is called tramadol. Tramadol is a partial mu agonist and also it inhibits noradrenaline and serotonin reuptake. The question I asked is, pethidine, can I give it in biliary colic? 100% yes. Because it has atropine-like action, so it has antispasmodic property. Okay, Rahul, thank you. Thank you. What is the drug used for opiate de-addiction program? The opiate de-addiction program, we use 2 opioids. Either we give methadone for the patient or we give buprenorphine. Methadone or buprenorphine for opiate de-addiction program. What is the opioid used for traveler's diarrhea or anti-cancer drug induced diarrhea? I think most of you will answer this. Which opioid is given for treating traveler's diarrhea or anti-cancer drugs induced diarrhea? I'll give you a clue. The answers, the letter starts with L. Yes, it is loperamide. The name is loperamide, which is an opioid used for non-infective diarrhea, traveler's diarrhea, and anti-cancer drug induced diarrhea. It is loperamide. Coming to the next question, which of the following is not used to decrease craving in alcohol dependence? Now, naltrexone, topiramate, acamprosate, all these 3 drugs are known to decrease craving in alcohol. The one which doesn't decrease craving is disulfiram. What is the mechanism of disulfiram? It inhibits an enzyme called aldehyde dehydrogenase. So what happens if it inhibits aldehyde dehydrogenase? There is increase in acetaldehyde level, and that will cause nausea, vomiting, chest discomfort, palpitation. So because of that, suppose somebody is on disulfiram and if they drink alcohol, they don't get the pleasure. That's why it is also called as and abuse. So it is used for aversion treatment of alcohol dependence. So aversion therapy, we use disulfiram. And please understand, disulfiram should be given for highly motivated individuals. Now, what is the meaning of disulfiram-like reaction? Like reaction. Now, tell me one antibiotic which is used for amoebiasis, which if you take with alcohol can lead to disulfiram-like reaction. Please answer that. Which drug used in the maintenance in the opioid? There is similar. Yes, see, remember, suppose somebody is opioid dependent. So I want to de-addict them. To de-addict, we use 2 drugs. Either I use methadone or I use buprenorphine and gradually reduce the dose and stop it. So de-addiction of opioid can be done with methadone or buprenorphine, Pallavi. The amoebiatic drug which is going to cause disulfiram like reaction is very good. Metronidazole, this is tested frequently. Metronidazole, yes, very good, very good. Coming to another thing which we need to discuss is drugs for smoking cessation. So we have a drug called varenicline. Then we have a drug called bupropion. And then nicotine replacement therapy. So for smoking cessation, we have three modalities: varenicline, bupropion, and nicotine replacement therapy. What is varenicline? It is a nicotinic partial agonist. Bupropion is NDRI. NDRI means noradrenaline dopamine reuptake inhibitor. So what is the most effective treatment among this? The most effective is varenicline. Varenicline is the most effective drug for smoking cessation. Correct? Now, tell me some SNRI, you know. SNRI drugs. I'll give VMD. Yes, buspirone is not antidepressant. Don't confuse bupropion and buspirone. Bupropion is an antidepressant. It is called atypical antidepressant, which is also used for smoking cessation. Buspirone is anti-anxiety drug. Remember bus, who will do the bus sound? Snake. So when you see the snake, anxiety, so buspirone is for anxiety. It's a 5-HT 1A partial agonist. It's a 5-HT 1A partial agonist. Can anybody tell me which one is 5-HT 1B 1D agonist drug? So please answer me. 5-HT 1B 1D agonist drug. So what is CGRP antagonist? So the drugs either they end with GPANT or they end with Nazomab. So if they end with GPANT, these are for attack of migraine, Nazomab for prophylaxis of migraine. What is this 5-HT 1B 1D agonist? They are triptans. You know, sumatriptan, like that. Triptans are the drug of choice for acute attack of migraine. Now, can you tell me what is the most commonly used drug for prophylaxis of migraine? The most common drug used for prophylaxis of migraine. The name is called propranolol. Go to the next question. 56-year-old man with a history of type 2 diabetes presents to his physician for follow-up. He complains of recurrent hypoglycemia. His medication. Which of this medication is most likely for hypoglycemic reaction in this patient? So options are glimepiride, glucagon, metformin, acarbose. You have to answer me this. So answer for this question is A, glimepiride. So what should I know about antidiabetic drugs? Which antidiabetic drugs cause hypoglycemia? Insulin, sulfonylureas. SU means sulfonylureas and all of them start with gli. For example, glimepiride, gliclazide, glibenclamide, like that. and one more is meglitinides. They end with glenide. So these three drugs can cause hypoglycemia. Let me repeat: insulin, sulfonylurea, and meglitinide. Metformin is not going to cause hypoglycemia. See, this is the normal glucose. If it goes up, diabetes. If it comes to normal, then fine. If it goes below normal, it is called hypoglycemia. Metformin will make the sugar normal. It will not allow it to go down. What drugs will cause weight loss? The GLP-1 agonist. Then SGLT2 inhibitors and pramlintide. Now tell me which antidiabetic drugs are approved for obesity also. The one which are approved for obesity also are, if you want to become lean, liraglutide. If you want to become slim, semaglutide. And recently we have another drug called tirzepatide. So 100% these can be tested because it is making noise everywhere. In the media, in the social media, everywhere. Now tell me, what drug can increase GLP-1 and GAP levels? They are DPP-4 inhibitors and the names end with gliptin. The names end with gliptin. Now tell me which gliptin is safe in renal failure patient. You have to tell me. Yes, Devacat tirzepatide works on GLP-1 and GAP. It's an agonist. But what drugs will increase this level if they ask you? The DP4 inhibitors will increase the level. Tirzepatide is a GLP and GAP agonist. Very good. Tell me which is safe in renal failure. Gliptin. Yes, very good. The gliptin safe in renal failure is linagliptin. So Lina को लेना ही है renal failure में. Linagliptin safe. But nowadays the testing is mainly by SGLT2 inhibitors. Sodium glucose transporter 2 inhibitors. They end with gliflozin. Point number 1. What is the adverse effect they produce? They test. They cause glycosuria. They allow glucose to go in the urine. So who will enjoy that? Bacteria. So what will happen? UTI. Third, the fungus will also grow. Fungal genital infection. These are very common. Now where it is gliflozins are used nowadays? Now they are not only used for diabetes, they are now used to give in CHF. They decrease mortality. Mortality means death rate. They are also used in cardiovascular disease. They decrease the risk factors. And number 4, they are also used in chronic kidney disease. Yes, you are right, nephrotoxic. They can also cause diabetic ketoacidosis. They can also cause Fournier's gangrene. They can also cause fractures, amputations of lower limb, but these are rare. But common are these 3. That's why I have written only these 3 important. Gliflozin are trending drugs. Recently they had asked which drugs decrease mortality. CHF. It is gliflozins. Now you have to tell me what drugs decrease mortality in CHF. I told you in the classes plenty of time. The mnemonic is sub. Now what is sub for? S for spironolactone, SGLT2 inhibitors, A for ACE inhibitor, ARB, and R9. What is B for? B for beta blockers. So let me repeat again. Which drug decrease mortality in CHF? S for spironolactone, SGLT2 inhibitors, A for ACE inhibitor, ARB, R9, and B for beta blockers. They can ask you like this, decrease mortality, or they can ask you drugs increasing longevity. That means people can live longer. So these are the specialty of SGLT2 inhibitors. Please know it. Moving on to the next question. Which of the following drug acts by inhibiting cell wall synthesis? Yes. So before I answer this, let me tell you the targets of antibiotics. Cell wall, mainly beta-lactams. Tell me some beta-lactams, sir. Penicillin, cephalosporin, monobactams, carbapenems, and vancomycin. The drug acting on cell membrane, it is daptomycin and polymyxin. The one which inhibit protein synthesis, though binding to 30S, the mnemonic is TEAM. I'm just telling you the highlighted point. T for tetracycline, AM for amyl glycoside. The one which act on 50S, the mnemonic is MCQ. What is M for? Macrolides like azithromycin. C for clindamycin. Q for quinapritin, dalfapritin, they are called streptogramins. Other drugs which bind to 50S are chloram, phenicol, and a drug used in tuberculosis called linezolid. Then the one which inhibit DNA gyrase, they are called fluoroquinolones. How they end with? Fluoxetine. And then we have drug which inhibit folic acid synthesis, and the name is sulfonamides. PAS and dapsone. So what you have to tell me now? PAS, dapsone. What is the mechanism of an anti-cancer drug? Methotrexate. What does it inhibit? So methotrexate, proguanyl pyrimethamine, trimethoprim inhibit a specific enzyme. Can anybody tell me what enzyme do they inhibit? They inhibit dihydrofolate reductase. MTX means methotrexate. Yes. So we have discussed the mechanisms here. So the answer for this cell wall synthesis is cephalosporins, which is a beta-lactam. Erythromycin, thromycins are macrolide, they inhibit protein synthesis. Daptomycin, cell membrane, sulfonamide, folic acid synthesis. So if I know the basics, I can come to the answer. Okay. Now malaria is a favorite for FMG exam, so let's go in detail. A patient visited an endemic area of falciparum malaria and was given prophylaxis. How many weeks he needs to take the drug during travel? Not during travel. After leaving endemic area. We'll do like this. Just a minute. Yes, sorry, there was a confusion here. A patient visited an endemic area of falciparum malaria and was given prophylaxis. How many weeks you need to take the drug during travel? So 7 days, 14 days, 28 days during travel. There's a trick in this question. Just read it. Now let's come to the answer later. First of all, prophylaxis of malaria is tested frequently. Prophylaxis, if you are traveling for less than 6 weeks, then the drug is doxycycline. It started 1 to 2 days before journey. This is a start, end of the journey. So it is taken daily. And after coming back, it has to be taken 28 days daily. Okay, that is one approach. If the journey is more than 6 weeks, then we have mefloquine. Mefloquine is longer acting, so it has to be taken 1 week before journey. This is the start and end. So it is taken once weekly. during travel, and after coming back it has to be taken for 4 weeks, and it is once weekly. So 2 drugs are given for prophylaxis. Doxycycline, daily it has to be taken before journey 1 to 2 days, during journey, and coming back 28 days. Mefloquine weekly once, take 1 week before journey, every week in the travel, and 4 weeks afterwards. So if you know this basic, come back to the question. So they are asking how many weeks he needs to take the drug during travel. So during travel he has to take every week. So this is not there, this is not there, this is not there. Entire duration of travel he has to take, and after coming back he has to take for another 4 weeks. And most of you have answered it correctly. The answer is D. Apart from this, how do you treat Vivax? For Vivax, still today, the best drug what we can start is chloroquine. CQ means chloroquine plus primaquine for 14 days. So if I give chloroquine for 3 days, primaquine is given for 14 days. Why 14 days, sir? It is for radical cure. Radical cure means to kill hypnocytes. Falciparum, we use artemisinin combination therapy. It depends which part you are treating, northeast or rest of India. Northeast, we use the combination called artemether plus lumefantrine. Remember as me, Rumi, Artemi. Rest of India, I'll write here. You give artesunate. Remember SU plus sulfadoxine pyrimethamine combination. So go through this again. Vivax, it is still chloroquine with primaquine. Falciparum, we follow artemisinin combination therapy. Northeast, it is me. Rest of India, it is SU. Please remember that. Suppose somebody had cerebral edema or complicated malaria, the drug of choice is IV artesunate. Sir, how do I know that in the question? They will give fever, chills. Along with that, patient will have CNS symptoms like delirium, confusion, seizures. Then you have to give IV artesunate, and then you can go for oral drugs, that is artemisinin combination therapies. Next, malaria in pregnant women is also being tested. For Vivax, I can give chloroquine for 3 days. But I don't give primaquine in pregnancy because it can cause hemolysis in the baby. So I don't want to give. Falciparum, if it is first trimester, I can give quinine plus or minus clindamycin. Quinine is safe. For second and third trimester, we can give artemisinin combination therapy depending on the place. Suppose pregnant lady develops cerebral malaria or complicated malaria, it's an emergency, so I will give IV artesunate. IV artesunate. So malaria is must know topic for you all. Now before I move on to this, some of the infections I will ask you. What is the drug of choice for herpes 1, herpes 2 and varicella zoster virus? It is acyclovir. Now tell me what is the drug of choice for cytomegalovirus? That you have to answer me. Influenza, we use oseltamivir and it inhibits neuraminidase. Oseltamivir. Then hepatitis B virus, the drug of choice is tenofovir. Yes, come on, what is the drug of choice for cytomegalovirus? Ganciclovir. It is ganciclovir. Various virus. Coming to the next question. Which of the following drug can cause the side effect shown in the picture? So let me zoom the picture and show you. You can see this line redness, and this is called flagellate dermatitis. So which drug will cause that? It is done by bleomycin. So bleomycin will cause that flagellar dermatitis. So some of the important adverse effect of anti-cancer drugs, let me revise. The chemo man concept. Remember the cisplatin, carboplatin, they are ototoxic and nephrotoxic. Vincristine can cause peripheral neuropathy, you can see the periphery. V. Then bleomycin and busulfan, lung toxicity, fibrosis. Then daunorubicin, doxorubicin, trastuzumab, they can cause cartoxicity. Cyclophosphamide can cause hemorrhagic cystitis. Hemorrhagic cystitis. Now you have to tell me, how do you prevent methotrexate toxicity? What drug we will use? Tell me. How do you prevent hemorrhagic cystitis by cyclophosphamide? How do you prevent cardiotoxicity by doxorubicin? Tell me. Methotrexate toxicity I can prevent by giving folinic acid. Hemorrhagic cystitis, I think most of you are not responding. Why? Have you left the anti-cancer topics? Never leave this topic. I told in the classes also, please remember the most common adverse effect and how do you manage. Cardiotoxicity by doxorubicin, we use a drug called dexrazoxane. It is an iron chelator. And most commonly used anti-cancer drug for solid cancer is cisplatin. So if you don't know any anti-cancer drug, and if they ask you what is the anti-cancer drug used for solid cancer, write cisplatin. Okay, coming to the last question. This will be the last question for you. Patient was on chemotherapy for non-Hodgkin's lymphoma. Leukocyte count is now 2000. So it is low. Which of the following drug is effective in this condition? When the WBC count is lesser, then we use filgrastim. Filgrastim is granulocyte colony stimulating factor. Then we have oprelvecin. Kin means interleukin 11. So it's an interleukin 11 analog. And we use it to manage thrombocytopenia due to cancer drugs. Answer is not B. Answer is A. This is for thrombocytopenia. Thrombocytopenia due to anti-cancer drugs. Anything ending with poietin, it sounds like erythropoietin. It is to manage anemia. Anemia due to drugs or anemia due to CKD. Amifostin is a radioprotector. And also this drug, amifostin, is also used to prevent cisplatin-induced nephrotoxicity. So these are the commonly asked drugs. Now tell me, which anti-cancer drug can cause hand-foot syndrome? Tell me. It is 5-fluorouracil. And one more drug is called capecitabine. So these are commonly tested in the exams. So with these most expected questions, I have tried to cover plenty of high yield points in this video session. I hope it benefited for your FMG exams. So you are in the end of preparation. You have really done your best thing. And don't panic at this point of time. At this point of time, what is required is confidence. Tell your mind that you are prepared really well. I don't remember what happened with the previous exams. I do not remember those things. I want to remember all these subjects what I've studied, that is what I remember. I don't remember what happened in the previous exam and everything. I will be in the present situation, I'll be more confident, I will crack this exam, I will target 250. So that should be your goal at this point of time. So with that, I give you the best wishes. Not only best wishes, good luck, because it's also the luck which matters the most. So I wish the good luck and the grace of God come with flying colors, and please do message me after that. So any questions, any queries, so you can ask me. I am there for another 2-3 minutes. So please do ask me that. And don't worry about your GT scores, whatever scores, what you have done, it's already done. You have few days left out. Revise your notes, revise the MCQs, do more and more MCQs. That's it. Don't look into others what they are doing. You do your preparation. That's it. And never leave any subject. Study all the subject and go, because I've seen students failing with 1 mark and everything.